All right, this is review over cardiovascular physiology. I'll have another video on vascular anatomy. This will be a little bit long, but I will talk fast. Okay, so the initial part, talking about the heart, we do have to clear up some basic anatomy first to talk about the physiology. So here's a great depiction of the heart in the left here. So we have to know our chambers. So left atrium right here, left ventricle there, right atrium, right ventricle. We have to know our valves. Tricuspid valve between the right atrium and right ventricle, mitral valve between the left atrium and left ventricle. Those together are atrioventricular valves, or our AV valves. Now, these two valves up here are semilunar valves. So the valve between your left ventricle and the aorta is the aortic valve. The valve between the right ventricle and the pulmonary trunk is the pulmonic valve. So together those are called the semilunar valves, or SL valves. You also have to know your great vessels. So what vessels are bringing blood to the right heart from the body? Superior vena cava, so bringing blood from the head, neck, and upper extremities. Inferior vena cava, bringing blood from the trunk and lower extremities. And also we know the coronary sinus is dumping blood there too, but it's not a great vessel. So what's bringing blood back to the left heart? The pulmonary veins. They're bringing oxygenated blood back from the lungs. So our veins bring blood to the heart, arteries take blood away. So what arteries or what vessels take blood away from the heart? From the right ventricle, the blood's ejected in the pulmonary trunk, and that splits into the left and right pulmonary arteries. And this is taking deoxygenated blood to the lungs to get oxygenated and come back to the pulmonary veins. And then from the left ventricle, we inject blood into the aorta, which goes to the body, the rest of the body. So you have to be aware of all those. So what happens in the cardiac cycle? So diastole and systole, you can break this down into smaller components, and there's different stages just of left ventricular contraction, but I just like to do early and late diastole, early and late systole. There you go. So early diastole, early diastole, the heart is filling, so it's relaxed and filling with blood. The atrioventricular valves are open, the SL valves are closed. So blood is coming into the right heart from the superior vena cava, inferior vena cava, coronary sinus. Blood is coming to the left heart from the pulmonary veins, and they're filling, and blood is going through the atria into the ventricles, and they're filling it from the bottom, glug, 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 glug. So blood's passing through the AV valves. But the SL valves are closed because we don't want to eject blood yet. This is diastole. Blood is not ejected until we're in systole. So late diastole, the atria contract, so the SA nodes have depolarized because the leaky sodium channels, they hit their threshold of negative 40 millivolts, and the atria contract simultaneously, pushing blood into the ventricles. And then the AV valves close right after the atria push their blood into the ventricles, closes behind that blood. And those valves are really important because they're going to prevent regurgitation in the next phase of the cardiac cycle. So this extra blood that the atria push into the ventricles, sometimes refer to that as atrial kick. So that contributes to cardiac output. Someone with atrial fibrillation, their atrias are just doing this. They're not contracting right before the ventricles like they're supposed to. We're missing some of that blood getting pushed in there. And then our cardiac output will be decreased. You might not notice it at rest, but someone gets up, they walk, they try to exercise, and they get really short of breath. It's because their cardiac output can't increase to match their activity level. Okay, so AV valves close. When they close, they create a turbulence of blood. The turbulence of blood from the valves closing is what creates the S1 heart sound, or what some people refer to as lub, but it's called S1. So S1 also marks the end of diastole, so important marker there. So ends diastole. Next, systole, early systole, what happens? The ventricles contract. Remember, there's a delay between the atria and the ventricles contracting, and that's because the atrioventricular node in the conduction pathway, there's a delay of 120 to 200 milliseconds that allows the atria to fully contract before the ventricles contract. So early systole, the ventricles start to contract. At that time, all four valves are closed. There's two times in the cardiac cycle that all four valves are closed. This is the first one. AV valves are closed, semilunar valves are closed, and the ventricles are contracting. So, and they're building pressure up. We want to increase the pressure in the right ventricle because if we want to go to late systole and inject blood into the pulmonary trunk, the pressure in the right ventricle has to be greater than that of the pulmonary trunk. Same thing in the left side of the heart, the left ventricle pressure, left ventricular pressure has to be greater than the pressure in the aorta to open that aortic valve. Okay, in late systole, we've built up enough pressure that SL valves open and blood is ejected from the right ventricle. It's ejected into the pulmonary trunk, which goes to the pulmonary veins and sends deoxygenated blood to the lungs. And then the left heart, blood is ejected into the aorta, and that sends oxygenated blood to the body. And then when those semilunar valves at the end, right after they ejected its blood, that's our SL valves close, and the turbulence of blood from the SL valves closing creates our second heart sound, or our S2, or some people refer to as dub. And that marks the end of, basically the end of systole. So, but that is one little stage here where now when the SL valves close, the AV valves are still closed for a moment. So right before right at the end of diastole, it's our end diastolic volume. So at the end of diastole, our heart, our ventricles are filled with the most blood possible. Now at the end of systole, we've ejected blood. There's still blood in the heart, right? Because ejection fraction normal is like 55 to 70%. What's left over is the blood that was left behind. We call it the end systolic volume. It's when the heart is the least filled with blood, and the difference is the stroke volume. So, but anyway, the SL valves closed, the AV valves are closed, the right and left ventricular pressure is very low, and then that pressure differential allows the tricuspid mitral valves to open and blood starts flushing back in. Look at the heart sounds, S1, S2. So S1 is from the AV valves closing, S2 from the SL valves closing. So lub dub, lub dub, lub dub, lub dub. So you can see at rest, just resting heart rate, we're going to spend more time in diastole than systole. So lub dub, lub dub, lub dub. So more time in diastole. Let's move on. So there's two other heart sounds that you could hear. Could hear, yes. So in S3, you can't really see them. S3 and S4. So this is how we talk about S3 and S4. S3 occurs early in diastole. So we know what happens in early diastole. The heart is filling. So as AV valves, we just talked about, open back up, blood flushes into the ventricle, it hits the ventricle wall. That's what creates the S3 heart sound. It can be normal in some young, healthy patients who have a nice compliant, which means like a stretchy left ventricle, but it could also be due to pathology. So this happens early in diastole. So you would say lub, dub, dub, lub, dub, dub, lub, dub, dub, lub, dub, dub. And we can use the state Kentucky, 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 Kentucky. So there's a little delay between Ken and Tuck because it's systole. But S3 is happening right after the SL valves close because this is when the AV valves pop back open and blood splashes into the heart and hits the ventricle. So Kentucky, Kentucky, Kentucky. And I drew S3 and S4 smaller because they're lower amplitude. They're not as loud as S1 and S2. Whereas split S2 or split S1, they'd be just as loud, and they're not. So then S4 is almost always pathologic. So S4, how we talk about it, S4 happens before S1. So it's late in diastole. This is when the atria are contracting. They're pushing blood into the ventricles. And this happens when there's a stiff ventricular walls. And blood is getting forced into the ventricles. And because they're stiff, it creates some turbulence of blood. And that creates this S4 heart sound. So we use the state Tennessee. So Tennessee, Tennessee, Tennessee. So the 10 and S are real close. The C is after delay. So we went over this. It'd be lub dub dub, lub dub, lub dub, dub lub lub, something like that. Okay, but use those two states. All right, where do you listen to the heart sounds? Look at this fantastic rib cage. So there's 4 basic sites. There's more like Erb's Point and stuff. This is just talking about the valves. You'll learn more about this from your nursing instructors. So number 1, this is the second intercostal space at the right sternal border. So right here. So right second intercostal space just at the border, just lateral to the edge of the sternum. I got it. Number 2 is the pulmonic valve. So we listen to that in the left second intercostal space, right at the sternal border. And then, which makes sense because they're at the top of the heart, or the base of the heart, the superior aspect of the heart. And number 3, we come down to the fourth intercostal space, still at the left sternal border. That's where we listen for the tricuspid valve. We come down to the 5th intercostal space, but now we move over to the mid-clavicular line. We've used this before. We make an imaginary line through the clavicle, carry that down, and listen to the 5th intercostal space, and that's for the mitral valve. All right, the conduction system of the heart. So the electrical activity, how does this work? So the SA node is the pacemaker of the heart. This is what starts the depolarization or starts the conduction pathway through the heart. Now the heart does not need extrinsic innervation to beat on its own. We need extrinsic innervation, which we'll see in the next slide, to speed the heart up and make it contract harder or to slow the heart down. Before we get to that, let's talk about the intrinsic innervation, so the internal innervation of the heart. So sinoatrial node, why is it the pacemaker of the heart? Well, let's just stop right there. Look at to the right, this little graph here. We see these waveforms, right? This is the potentials or charge potentials of the nodal cells in the SA node. So how does it beat on its own? We notice in this phase 4, sodium is slowly leaking in. So the resting potential of these nodal cells is negative 70 millivolts. It's not, so like the myocytes, the muscle cells in the heart, their resting potential is negative 90. So these depolarize a lot easier because all we have to go is from negative 60. Well, threshold's negative 40, then we depolarize. But you see this little up curve right away. Every time we repolarize, there's an up curve, up curve. What that means is sodium starts leaking in immediately. It's leak. We get negative 40, and then we depolarize because other sodium channels open. Sodium rushes in. That's depolarization. We repolarize by potassium moving out, and then as soon as we repolarize, we start having sodium leak in right away. There's no flat line here because there's no break. Immediately positive charges are leaking in. And you see it goes 4, 0, 3. There's no 1 and 2 because those are in the cardiac myocytes when they have the plateau phase, and we'll see that here in a little bit. Okay, these leaky sodium channels. So this is going to depolarize, I don't know, 60 to 80 times a minute, which is most people's resting heart rate is in the 50s or 60s or 70s or 80s, somewhere around there, although normal heart rate is 60 to 100. So the SA node, the depolarization is carried to the left ventricle through Bachmann's bundle. Internodal fibers pass through the right atrium, and so Bachmann's bundle, left atrium. Internodal fibers carry the signal through the right atrium and to the atrioventricular node. So in the AV node, what's special about this? SA node's the pacemaker. AV node has a delay, I said earlier, 0.12 to 0.2 seconds, or we could say 120 to 200 milliseconds. Remember that delay is important because that allows the atria to fully contract before the ventricles contract. It also will show up on your ECG, your electrocardiogram, as the PR interval, and that's the normal PR interval that you should see, which is 3 to 5 little boxes, and 5 little boxes would be one big box. Okay, atria have contracted, push the blood into the ventricles. Now the bundle of His, this gets carried to the bundle of His, and then that splits into a right bundle branch and a left bundle branch. These are located in the intraventricular septum, so the cardiac myocardium, the myocardium between the ventricles, and that's carried along the walls of the ventricles to the Purkinje fibers. So Purkinje fibers on the left, Purkinje fibers on the right, and that's it. And then as the ventricles are depolarizing, the atria are repolarizing, and then we start over from the beginning. And that your heart has this pacemaker effect, and hopefully it lasts a very, very, very long time, and your heart doesn't stop. Okay, this is what a cardiac myocytes electrical activity looks like. So here we do have that phase 1 and 2. So the resting phase is phase 4. We don't have that uptick where we're just having positive charges move in. There's no leaky sodium channels here. So cardiac myocytes are reliant on the SA node in this conduction pathway to carry this electrical signal through the heart. Resting potential of the cardiac myocytes is negative 70 millivolts. Okay, then we don't have a really threshold here necessarily. We just have depolarization from this pathway coming through the heart, and we have sodium channels open, they rush in, and then we have our depolarization. Then potassium starts moving out. We should just repolarize. But something happens here during phase 1, potassium starts moving in, but then right here at this point, potassium is moving out. Where at this point, calcium channels open, calcium starts moving in. So in phase 2, what's actually happening is potassium's moving out and calcium's moving in, and it creates this plateau phase and allows the cardiac myocytes to squeeze and just stay squeezed for just a tiny delay there to make sure they squeeze all the blood out and they relax. Squeeze all the blood out and they relax. We talk about sympathetic nerves. They're not only going to speed the heart rate up, positive chronotropic effects, they're going to have a positive ionotropic effect. What does that mean? It allows ions to move in better, more or less, like calcium move in to the myocardium better, and it makes the heart squeeze harder. Then in phase 3, right here, what happens? Calcium channels close and potassium continues to move out. So potassium channels open at the beginning of phase 1. Then phase 2, calcium channels open, so calcium rushes in. Then calcium channels close, potassium continues to move out, and we repolarize in phase 3. So this is all the phases 0, 1, 2, 3, 4, where the nodal cells don't have phase 1 and 2 because they don't have a plateau phase. Now here's what cardiac myocardial cells look like. Cardiac myocytes, that looks awful. But the cells are kind of like skeletal muscle. They have the same contractile proteins, actin, myosin, troponin, tropomyosin. But the difference is they're not going to be multinucleated. So they're going to be striated like skeletal muscle, but not multinucleated, one nucleus per cell. They're going to be connected. There's a little branching. This is branching between the cells, so they branch together because these have to contract in a very perfect, nice rhythm. We call it, or most books talk about it, they call it a functional syncytium. You don't need to know that term. It means it works together really well in a nice pattern. Also between the cardiac myocytes that's unique, these little things called gap junctions. And gap junctions, well, when this myocyte here depolarizes and sodium moves in, sodium can also pass directly to the next myocyte, and then the next myocyte will help it depolarize. That's how it gets carried through the heart so well. So on the left, here's the intrinsic innervation, the conduction pathway we already talked about. Well, now we see this red line and green line. What does that mean? So this is our extrinsic innervation, right? We know all these organs, other than blood vessels, have a dual innervation from the autonomic nervous system of parasympathetic and sympathetic nerves. So parasympathetic nerves, they're going to send signals to the SA and AV node, basically. And this is the vagus nerve. The vagus nerve is carrying this parasympathetic signal to the heart. And it's going to have, we call a negative chronotropic effect. Chronos means time, so negative chronotropic. It's going to slow the heart down. Now the sympathetic nerves, if those are signaled and fire, that's going to have an opposite effect. It's going to have a positive chronotropic effect. It's going to speed the heart up, but it's going to have the second effect called a positive inotropic effect, and that's where we make the heart squeeze harder. We increase contractility. So we have heart rate and we have contractility, how hard the heart squeezes. Now, you may take note, the parasympathetic nerves do not have a negative inotropic effect. They just slow the heart down. Okay, and it's a constant balance between the two. So if we want to speed the heart rate up, we actually have to inhibit the parasympathetic nerve, inhibit the vagus nerve, stimulate the sympathetic nerves. If we want to slow the heart down, we have to inhibit the sympathetic nerves, stimulate the parasympathetic nerves, and these are all coming from the cardiac acceleratory center in the medulla of the brainstem. Okay, I think that's all we need to talk about there. Oh yeah, some parasympathetic nerves are going to dump off acetylcholine to bind receptors here, and then we know to muscarinic receptors. And then we know sympathetic nerves are going to dump off epinephrine, which is going to bind to beta receptors, specifically beta 1 receptors. That's why beta blockers will block those receptors. All right, this is just comparing the two waveforms again, so we can see the nodal cells, the leaky sodium channels, we hit negative 40-ish, and then we have depolarization of sodium moving in, repolarization of potassium moving out, no plateau phase. Cardiac myocytes, a more negative resting potential of negative 90, so we have depolarization. Then we have this phase 1 and phase 2, it's plateau phase, so sodium channels close right here, calcium channels close right here, potassium continues to move out, and we fully repolarize. So here's a basic ECG. All you need to know is the basics. You'll learn everything else later. So we see a P wave. That's one positive deflection. That's due to atrial depolarization, right? We put these electrodes on the chest. We're picking up electrical activity through the chest wall of the heart, right? It's electrical because we're having movement of ions. And you guys already know cations have a positive charge. You move them in and out of the cells. You're going to change the potential of the cells. So we have this delay here between the P and the R, the PR interval. So PR interval should be 3 to 5 little boxes. These are big boxes. Each big box accounts for 200 milliseconds. I didn't draw these in here, but there's 5 little boxes in one big box. Each little box is 40 milliseconds or 0.04 seconds. So then we have a negative deflection called the Q, then a positive called the R, negative called the S. So this is called the QRS complex. So this depicts ventricular depolarization, so the ventricles contract. So while the ventricles are depolarizing, the atria are repolarizing. That's why we don't see any kind of electrical activity or deflection in the ECG, because the electrical activity in the ventricles depolarizing is much greater than the electrical activity in the atria repolarizing. We have a delay here for the ventricles to repolarize. So it's called the ST segment, ST. And the T wave represents ventricular repolarization. So you just need to know those basics. We'll talk about QRS we talked about the PR interval. You talk about the QT interval. So from Q to T, N to T, that's the time it takes for the full electrical activity through the ventricles to depolarize and repolarize. That can get prolonged or shortened by lots of different things you'll learn about. Okay, cardiac output. How do we calculate cardiac output? You need to know these formulas. So it's heart rate times stroke volume. Heart rate times stroke volume. So just at rest, let's say this is just generic numbers. Let's say your heart rate is 75 beats per minute. So you multiply it by stroke volume, which is measured in milliliters of blood. So 75 times 70, which is the math, roughly 5,000 milliliters or a minute, which we call 5 liters. So about 5 liters a minute. So cardiac output is measured in volume per minute, measuring how much blood the heart beats or ejects in a minute. But we can do things, let's say your heart rate increases, your stroke volume increases, you can significantly increase your cardiac output. Okay, if you're exercising, your cardiac output can easily go up to 10 liters, 15 liters, 20 liters a minute. Okay, and we increase our cardiac output from the heart directly by increasing the contractility, making the heart squeeze harder, which might increase stroke volume, and they have those positive chronotropic effects by increasing heart rate. And we'll learn a little bit later here about preload, how preload ties into this, and it's really important because the blood doesn't get to the heart, it can't pump the blood out. Now stroke volume, so how do we calculate stroke volume? Well, it's our end diastolic volume, and we subtract our end systolic volume from that. I already talked about this. At the end of diastole, well, the heart's the most filled with blood. The end of systole, the heart's the least filled with blood. If you separate that, subtract those, well, what the difference is the amount of blood that left the heart, which makes sense. So ejection fraction. So this is the value you're going to use more often than calculating stroke volume or directly cardiac output when you're talking about patients and evaluating for heart function and evaluating patients with heart failure. So ejection fraction is stroke volume divided by end diastolic volume. So let's say, we use a couple different numbers, but let's say your stroke volume is 70. So if 120 subtracted by 70 would be 50 milliliters, right? That's your stroke volume. You can calculate this difference. So, let's say our end diastolic volume is 40, right? 40, so that'd be 80. So how we calculate this, put 40 over 120. Well, that'd be really low, right? Or sorry, that'd be really low. So that would be like, if it was 80 over 40, that would be, what would be 80 over 40, 2 over 3. So it'd be, 40 over 120. Oh my God, sorry. That'd be a 33% ejection fraction. In this case here, the patient has a 60 milliliter end diastolic volume, 120 milliliter diastolic volume, so their stroke volume is 60. Put 60 over 120. That's 1/2. That gives us a 50% ejection fraction. Ooh, sorry, I butchered that. All right, so what else affects cardiac output? Well, these 3 things: preload, contractility, which we've already talked about, and afterload. So think about this not as cardiac output over a minute. Think about this as output from one contraction. So stroke volume. So one contraction of the heart and one ejection of blood. So let's say 70 milliliters of blood being ejected from the heart. Well, what factors tie into this? How do we know how much blood's going to get ejected? It's not just, well, it's, end diastolic volume versus subtracted, and you subtract end systolic volume. Well, sure, but what things can affect that? Well, the first one's preload. Preload's really important. This is blood returning to the heart, right? Blood coming to the heart from the superior inferior vena cava coronary sinus, right? And the blood comes into the right heart, gets ejected, sends to the lungs, gets oxygenated, it comes back to the left heart through the pulmonary veins, and that volume of blood is the blood we have to eject from the heart, or a certain percentage of that, depending on our ejection fraction. Well, if the blood doesn't come back to the heart from the venous return, we're not going to have that much, we can't increase our stroke volume, right? If we can't get the blood back, if we're hypovolemic, or we have venodilation, or whatever the case may be, we can't get blood back to the heart, well, guess what? You can't eject it from the heart if it doesn't get to the heart. So if we increase preload, we will increase cardiac output, because what we're doing essentially is we're increasing our end diastolic volume. We're getting more blood back to the heart. As long as the heart's working fine, and it contracts fine, the contractility is normal, we can push more blood into the heart, increase the end diastolic volume, and then the end systolic volume will stay roughly the same, and that's going to increase our stroke volume. Hopefully that makes sense. So how do we increase preload? Because it just is our venous return. So the musculovenous pump, so right muscle contraction in the lower extremities and trunk will help push more blood back to the heart. Venoconstriction, so more sympathetic stimulation of the veins will cause the veins to constrict and also return more blood to the heart. And also decreasing intrathoracic pressure. So if the pressure in our thorax decreases, that'll have less external force on the vena cava, or the vena cava, superior and inferior vena cava. That's going to allow more blood to return to the heart. We don't want to collapse those veins or push on them externally, because that'll decrease the amount of blood that gets back to the heart. So it would decrease venous return. So again, hypovolemia, someone's really dehydrated. If they had blood loss, which also causes hypovolemia, insufficient veins, so the veins aren't healthy enough. The veins are damaged and can't get the blood back to the heart. There's more examples, a couple. So that blood got to the heart, whatever the volume of preload that got back to the heart, which is going to help dictate the end diastolic volume, right? That's going to determine the end diastolic volume. What we're going to do with that volume of blood, how much of it are we going to squeeze out? Well, it's based on the function and the health of the heart, the health of the myocardium, how hard the myocardium is going to contract. So a healthy heart, well, it's going to eject a certain percentage of blood, 55 to 70% of blood. That's your ejection fraction. If we push more blood in there, so if we increase venous return, we increase preload, we'll just have to increase our inotropic effects, have the heart squeeze harder, right? And that's going to eject more blood. So if we increase contractility, we're going to increase cardiac output. And usually if you squeeze more blood into the heart, it's going to contract harder anyways, based on the Starling experiments. It's going to increase our cardiac output. So now we know what increases cardiac output: increasing preload, increasing contractility, which increases stroke volume, and increasing heart rate. This next part here is afterload. So afterload has an inverse relationship to cardiac output, where preload and contractility have a direct relationship. I mean, if they go up, cardiac output should go up. If we increase afterload, cardiac output could go down. So this is the resistance to outflow from the heart, right? So the higher the pressure in the aorta, let's say, or the pulmonary trunk, well, we know the ventricular pressures have to rise above those pressures for the semilunar valves to open. So if we're increasing that afterload, right, increasing the pressure the ventricles have to push against, well, that's going to increase the workload on the heart, and it could decrease output. So what would increase afterload? If you have a real stiff or calcified aorta, because remember the aorta is very elastic, it's an elastic artery, we need it to stretch out and then recoil. Increased diastolic pressure. So obviously if your diastolic pressure is high, well, that's the pressure that the ventricles are pushing against, whether you're talking about pulmonary arterial pressure or systemic blood pressure, which we're talking about arterial pressure, and also aortic stenosis. Okay, so this is talking about blood pressure. So what factors affect our blood pressure? Cardiac output. You increase cardiac output, you'll increase blood pressure. So it's based on your heart rate, your contractility, and increasing your preload, right? And then obviously increasing afterload would decrease it. What else affects blood pressure? Not just cardiac function, so total peripheral resistance. So these are your systemic arteries, right? Your arteries, okay? If we have increased resistance, right, meaning we constrict our blood vessels, our blood pressure will go up if all their factors stay the same. So increased sympathetic tone to the blood vessels. If we vasoconstrict our vessels, well, that's going to increase our TPR and increase our blood pressure. If we have vasodilation, so we decrease sympathetic tone to the smooth muscle of the blood vessels, we'll have vasodilation, and that will decrease our total peripheral resistance, which will decrease our blood pressure. So you give drugs that are vasoconstrictors, like pressors, you'll increase your blood pressure. You give drugs that are vasodilators, like dihydropyridine, calcium channel blockers, like nifedipine. That's going to cause vasodilation and decrease blood pressure. Okay, so blood volume. So what increases blood volume, right? So blood volume, if we make more fluid in those same pipes of the arteries, well, that's going to increase our blood pressure. So as long as the peripheral resistance stays the same, cardiac output stays the same, if we increase our blood volume, there's the same amount of space for more blood. That's going to increase the pressure. Like you're shoving more water into pipes, it's going to increase the pressure in a pipe. So this is dictated by our kidneys, not our arteries like peripheral resistance or the heart with cardiac output, our kidneys, right? So our kidneys control how much volume we have. So they affect water balance in the body. So the kidneys are filtering our blood all the time. Normal, textbook, filtration rate, or a GFR, is 120 milliliters a minute, but the kidneys can hold on to more water to reabsorb back into our plasma, or can reabsorb less. We pee more out. This is controlled through two hormones called antidiuretic hormone and aldosterone. Antidiuretic hormone gets released in increasing amounts as our osmolarity increases, which happens in dehydration or potentially increase, sodium intake, and that's going to cause increased reabsorption in the nephrons in the kidneys. We'll talk more about that later. You'll hold on to more water. On the other hormone, aldosterone. So aldosterone is directly controlled by this system we're going to talk about here in a second. Aldosterone causes increased water, or should I say increased sodium reabsorption in the kidney, which water will follow based on osmotic effects. And we're going to increase water and sodium reabsorption. It also causes increased potassium secretion. We'll touch on that. So what controls these things, other than osmolarity affecting ADH, is a system called RAAS, or renin-angiotensin-aldosterone system. And we'll go over the details of this, but the bottom line, if you activate the renin-angiotensin-aldosterone system, you'll have increased water and sodium reabsorption, which will increase your blood volume, and that can increase your blood pressure. Okay, here's this messy slide about blood pressure. So first of all, let's take some steps back. All right, where do we monitor our blood pressure? Because how do we know our blood pressure? Our body doesn't have a blood pressure cuff on our arm. That's how we, give some kind of estimate of our pressures. It's not a direct measure of blood pressure. It's kind of indirect because all we're doing is occluding the brachial artery with a cuff and then seeing where the pressure's in, measuring it that way. So we measure them in our neck. So where the common carotid artery splits into the external and internal carotid arteries, we can see that there. So at the bifurcation here, we have these special cells in this area called the carotid sinus. And the carotid sinus, these receptors are mechanoreceptors, which is referred to as baroreceptors. So the more you stretch that more, it's going to send more signals back to the brainstem saying, hey, blood pressure is going up. You have less stretch, it's going to say, hey, blood pressure is going down. So like barometric pressure, we're measuring the pressure of the atmosphere. Baroreceptors are measuring the pressure in the arteries right here. So information from there is going to be taken back to the brainstem through cranial nerve number 9. We know it's the glossopharyngeal nerve. And in the medulla of the brainstem, we have all of our cardiac centers and our vasomotor centers for affecting our blood vessels and affecting the heart. So, and then from there, we're going to send nerves to the heart. So we talked about the vagus nerve, parasympathetic, which would slow the heart down, and then sympathetic nerves, which would speed the heart up and make the heart contract harder. So those are your chronotropic and ionotropic effects. So if our blood pressure is going down, what can we do with the heart? Well, we can increase the heart rate, we can increase contractility. So we'll inhibit the vagus nerve, stimulate the sympathetic nerves, stimulate the sympathetic nerves. So if blood pressure is too high, well, we can inhibit the sympathetic nerves and stimulate the vagus nerve and decrease cardiac output. Okay, what about total peripheral resistance? Well, we also have sympathetic nerves coming from our brain, our brainstem. And those are going to send nerves to the arteries, right? And the arteries have smooth muscles in the walls. If we have increased sympathetic stimulation of the vessels, we call this sympathetic tone, increasing sympathetic tone. It will cause vasoconstriction, which will increase our TPR, which will increase our blood pressure. If we inhibit those sympathetic nerves, have less sympathetic outflow, we'll have less activity of the smooth muscle in the blood vessel walls, and with vasodilation, that will increase our total or decrease our total peripheral resistance and decrease our blood pressure. So we call this sympathetic tone. There's no parasympathetic nerves to the blood vessels, only sympathetic, and the more tone, the more outflow of the sympathetic nervous system, the more vasoconstriction we get, the more TPR we have, and then the more blood pressure. The more blood pressure, the higher the blood pressure. This last thing, the kidneys. So what's this whole RAS system? Well, the kidneys, we'll learn about this later. We learn about the structure of the nephron. You guys don't know that yet, so I'm not going to go over it. Basically, the kidneys they're having decreased perfusion. And what that really is low flow in something called the distal convoluted tubule and low sodium content in there, which is kind of an interesting way of doing that. Don't worry about that now. Either way, the kidney says, hey, we're not getting enough flow, we're not getting blood flow. Let's release this enzyme. It's an enzyme called renin. So renin's an enzyme. What does renin do? Well, the liver and the lungs are also implicated here. So the liver makes a protein called angiotensinogen. We know it's a zymogen. It ends in ogen, just like fibrinogen we learned about. It's not active, right? Or plasminogen, fibrinogen. It's not active. So how do you activate this protein? Well, renin converts angiotensin into angiotensin 1. Angiotensin 1 still doesn't do anything that you need to know about. So we need to convert angiotensin 1 to angiotensin 2. Angiotensin 2 is what has all the effects that we want to increase blood pressure. So angiotensin converting enzyme, or ACE, is actually made in the lungs. So that's another enzyme, and that's going to convert angiotensin 1 to angiotensin 2. So there's two enzymes here in two steps. Now, angiotensin 2, you need to know its effects. It has three main effects. Well, one's vasoconstriction, which doesn't really affect blood volume, but it has a sympathetic or sympathomimetic effect, causing increased vasoconstriction of blood vessels. The other two are going to affect blood volume. So number two, it's going to send signals, bind to receptors. So up here in the brain, so the hypothalamus, this makes antidiuretic hormone. Another name for that's vasopressin. So antidiuretic, the opposite of a diuretic effect, right? It's going to get stored in the posterior pituitary, not made there, and then released into the blood. What ADH is going to do is going to come all the way to the kidney, circulate to the kidney. It's going to cause increased water reabsorption. So we have more water. Holding on more water, increase our blood volume, increase our blood pressure. That's what ADH does. Angiotensin 2 also stimulates release of aldosterone from the adrenal cortex. And what happens here, it's going to act right back on the kidney, because the adrenal glands are sitting on top of the kidneys there, the suprarenal glands. It's going to bind to receptors in the distal tubule, and it's going to cause sodium reabsorption. Water is going to follow sodium, and that's what you have. Okay. We also have potassium secretion, but we'll learn more about that later. So this is how we affect cardiac output, affect total peripheral resistance, and affect blood volume to affect your blood pressure. This is showing the same thing here, but here we see aldosterone. So increased sodium reabsorption, increased water reabsorption, then increased potassium secretion. So we hold on to sodium and water, we pee out more potassium. I listed some basic drugs here. We talked about beta blockers, so they're blocking beta receptors in the heart, beta 1 receptors. That's going to decrease heart rate and decrease cardiac output. So if you want the heart to relax, you give some beta blockers, and it will lower blood pressure. Those are drugs that end in lol, metoprolol, nebivolol, all those good drugs. There's a bunch of them. Calcium channel blockers, so the non-dihydropyridines like diltiazem and verapamil, they'll bind to calcium receptors, and what they'll do is they'll slow down calcium receptors so the heart doesn't contract as hard, and that's going to relax the heart a little bit and decrease blood pressure. What about drugs that affect the blood vessels? So there's dihydropyridine calcium channel blockers, so those end in dipene, like nifedipine. And what they're going to do is block calcium channels in the smooth muscle of the blood vessels, so the blood vessels will relax, will decrease our TPR. So when the side effects of dihydropyridine calcium channel blockers, people get swelling in their legs because they're causing vasodilation. That can't happen. What else can we give? Oh, we're going to love this. So we can give ACE inhibitors. ACE inhibitors end in pril, like ramipril, lisinopril. There's a bunch of them. Enalapril. So they're going to block ACE. Hence ACE inhibitors, angiotensin converting enzyme inhibitors. You'll have less angiotensin 2, you have less ADH, less vasoconstriction, less aldosterone, and lower blood pressure. Other drugs, ARBs, angiotensin receptor blockers. They end in sartan, like losartan, telmisartan. And what they're going to do, they're not new, but they came out after ACE inhibitors, and they're going to block actual binding of angiotensin 2 to these receptors. So they're both going to affect blood pressure. And then also we have things like potassium-sparing diuretics and thiazide diuretics and loop diuretics, but we'll save those for the kidney. Blood pressure guidelines, the American Heart Association guidelines. Again, some of you aren't going to care about this. This is more like long-term working family medicine office, the blood pressure control thing here. So technically, normal blood pressure is less than 120 over less than 80. So I think it's 2017, they did a trial called the SPRINT trial, and they realized, okay, we need to tighten up blood pressure control, because we used to think, okay, you're not really hypertensive until you're 140 or greater and or over 90 or greater, and if you're like 130s, you're like pre-hypertensive. We've changed that. There's no pre-hypertension. There's normal elevated stage 1, stage 2. So to be normal, technically you have to be like 118 over 70 or 119 over 79 if using an electronic cuff. Elevated, so if your systolic pressure increases to the 120, so 120 to 129, but your diastolic is still less than 80, technically that's elevated. Right? Most patients in the hospital, they have blood pressure like, oh, it's really good, especially the hypertension. Stage 1, so 130 to 139 and or over 80 to 89. Stage 2, either 140 or greater and or 90 or greater diastolic. That's your stage 2 hypertension, and that obviously definitely needs treated. But even if you're in stage 1, people are making the argument this still needs treated because it's too high and you're going to have potential negative outcomes. So the chronic long-term effects of uncontrolled hypertension, heart failure, is putting more strain in the ventricles, which you should already understand. You can get left ventricular hypertrophy, and this can lead to heart failure over time. Chronic kidney disease, high blood pressure is awful for the kidneys. We'll talk about how exactly that happens, but it damages the vessels coming to the kidneys from the high pressures. And this is going to increase your risk of atherosclerosis and cardiac events because we know, and you're going to learn this, if you increase pressure, you're going to increase turbulent flow. You won't have as much laminar flow, especially on the little kinks and turns of the blood vessels, and there's a higher risk of endothelial injury. The Virchow's triad, one part of the Virchow's triad is endothelial injury, so that's going to promote atherosclerosis. Now, what do you care about more if you're in an acute setting? Hypertensive urgency and emergency. So this is a blood pressure of 180. I should say greater than 180 and or greater than 120 in diastolic. So an urgency, this means those pressures, but the patient is asymptomatic. So I feel fine. I don't need to go to the ER. They need to go to the ER. They don't have symptoms yet. Hypertensive emergency, they're having symptoms, and we call these symptoms of end organ damage. Vision changes, those little vessels in your retina, it's going to damage those. Might get blurriness and trouble seeing. Chest pain, those high pressures can cause chest pain. That's scary. And they can also cause really bad headaches. So what can happen, the actual events here, because the high pressures in your head, you can cause a stroke. High pressures in the heart can cause a myocardial infarction. And then high pressures in the aorta can cause an aortic dissection. So it's scary. And it can even cause acute kidney failure, potentially. So someone has a headache, they have chest pain, the vision changes, they need that treated ASAP. So this is showing an equation about blood pressure. So, okay, we have a systolic and a diastolic, right? So it means pressures go up in the arteries and down, up and down, up and down. But what's the average pressure? So there's this formula, mean arterial pressure, so MAP. It equals your diastolic blood pressure plus 1/3 the PP, or the pulse pressure. We know pulse pressure is systolic blood pressure minus diastolic blood pressure. So the pulse pressure can be widened or narrowed, and you learn all the different causes of that later. But measuring our average pressure, we take our diastolic pressure and we add 1/3 the pulse pressure. So if your blood pressure is 120 over 80, we take 80 plus 1/3 of 40, which is 1/3 of 40 is 13, right? So 80 plus 13 equals 93. That would be the MAP if your blood pressure is 120 over 80. So this is the arterial waveform. So if you took an ultrasound and you put it on one of the arteries and you mapped it, like any non-invasive vascular study, this would be your arterial waveform. It goes up as pressure goes up to your systolic blood pressure at the max, then it comes down, and the bottom is your diastolic pressure. This little notch with notches, not this one, it goes up, I should be clear, but the notch is down, so that's from the aortic valve closing. It's called a dicrotic notch. And this is triphasic blood flow. There's 3 sounds. You're going to swish, swish, and swish, like 3 swishy noises, and that means it's triphasic. If you'll hear 2 swishy noises, that's biphasic, and if you hear 1, it's monophasic. And as we decrease, that means there's less and less blood flow in the arteries. So if you can't feel a pulse, you use a Doppler, which is a little ultrasound machine. You put ultrasound gel over the skin, you put the little Doppler machine on there, and it can be triphasic. That's 3 sounds if you listen closely. Biphasic, and then monophasic. I'm sure you got that, and I sound really stupid doing it, but those are your waveforms. Okay, let's talk about arteries and veins, compare those, talk about capillary hemodynamics, and we're almost done. We're working fast here. Arteries, these are technically conducting vessels. They're taking oxygenated blood to tissues. They're delivering substrate for energy. They're delivering oxygen, hormones, all kinds of good stuff to the tissues. And they're at higher pressure, right? Everything's relative. So when we say, oh, your blood pressure is 120 over 80, we're talking about your arterial pressure. So there's different kinds of arteries. There's large elastic arteries like the aorta. They have a lot of elastic tissue. Medium muscular arteries, they've got lots of smooth muscle in them. So they have good vasoconstriction, vasodilation properties for affecting your TPR. So brachial arteries, femoral, radial, ulnar, carotids, things like that. And then arterioles, these also have smooth muscle in them, and they're controlling the opening to capillary beds. An example I used in class was someone has a sympathetic response, a fight or flight response. Well, we don't just constrict our vessels because it increases sympathetic flow. We want to decrease blood flow to our digestive system so we constrict those arterioles and put less blood into the capillary beds that are going to the GI system. But we want more blood to the skeletal muscles. Kids fight or flight. You might be running, sprinting, doing whatever. So we'll dilate the arterioles going to the capillary beds to the skeletal muscles and hopefully increase blood flow to the skeletal muscles, carrying more blood because they need more oxygen due to increased metabolism. Needing more ATP. So the vessel walls, the tunica adventitious, the outer connective tissue part of the vessel wall, the tunica medius where we have smooth muscle for vasoconstriction and dilation, the tunica intima, it's intimate, it's the inner layer, has a layer of subendothelial collagen, sometimes we call it a basement membrane. Then the endothelium, super important, the endothelium, that's the smooth inner part of the vessel that faces the blood. Obviously, this is an epithelial tissue, simple squamous epithelial tissue, and this releases things like nitric oxide and prostacyclin, which cause vasodilation and promote that and prevent blood clotting. So nitric oxide is really important. And drugs like PDE5 inhibitors, like Viagra and Cialis, that's what they do. They cause vasodilation by increasing nitric oxide production and more blood flow to the penis, which helps with erectile dysfunction in certain patients. So all vessels other than capillaries have all these three layers, just certain vessels have more smooth muscle, certain vessels have more elastic tissue, certain vessels have a thinner wall, certain vessels have a thicker wall. So we see these lines. What are the circles representing? This is laminar flow, layered flow. So the blood in the very inner part of the vessel is going to move faster, have a higher velocity than blood out closer to the endothelium is going to have a slower velocity. There's more drag against the vessel surface. So abnormal blood flow, it's a turbulent flow, right? We want to minimize turbulent flow because it's too much turbulence. It could damage the endothelium, which is going to promote blood clotting and atherosclerosis. We don't want either. So veins, they're considered capacitance vessels. They can hold a lot of volume. So usually they'll hold more volume than arteries. The general textbook number is they hold about 2/3 of the blood volume, and the arteries hold about 1/3 of the blood volume. So not only capacitance vessels, because we can steal blood for them. So think of it as a blood reservoir. Think of like, oh, you're getting dehydrated, your blood volume's going down. Well, the veins can constrict, venoconstriction, push more blood back to the heart and increase the volume of blood in the arterial system. That's why if you're dehydrated, you look at someone's peripheral veins, their subcutaneous veins you draw blood from, and their veins are like collapsed. You can't see them. Well, that's because there's less blood volume and the arteries are going to borrow blood volume from the veins. So the first thing that's going to happen is your superficial veins are going to collapse. We need less blood in them. That's one thing. They're also return vessels, right? What is their job? Veins bring blood back to the heart. They bring this deoxygenated blood back to the heart, right? Because the tissues for tissue respiration used up oxygen to make ATP. What are the byproducts of making ATP? Everyone knows this: CO2 and water, that metabolic water. CO2 is a waste product. We need to get rid of the CO2 so that blood goes back to the heart. We drop off CO2 and we pick up more oxygen. And we'll talk about that more in the respiratory system. So, and again, we talked about veins are affecting the preload, right? Muscular venous pump, venoconstriction, they're going to push more blood back to the heart. But again, pressures are relatively low. That's why veins in the lower extremities have valves. We'll talk about that. So what affects venous pressure, right? We're talking about arterial pressure. Venous pressure is completely different, right? Whether you're laying down, standing, walking, doing whatever, unless you're really exercising, what I'm trying to say is your positioning does not affect your arterial pressure. So positioning doesn't affect arterial pressure. You lay down, stand up, it's going to be the same. It's relatively the same. Maybe a little correction when you go from laying to standing, obviously. But as long as it's functioning properly, you don't have orthostatic hypotension, it's fairly stable. Venous pressures change significantly based on whether you're lying down, sitting, standing, or walking, like you're moving. So this is a column of blood. Our venous blood's like a column. So you stack up this blood, stack, stack, stack. So the blood in the bottom has the most pressure, the most inferior aspect. The most superior aspect of the blood actually has the lowest pressure. So around the heart, it can be anywhere from 0 to 10 millimeters of mercury. So this is called our central venous pressure. Usually it's like 8 to 12. Everything below that is going to have higher pressures. Everything above that is going to have lower pressures. And these are just some generic numbers. So if you're standing here at your feet, the venous pressure in your feet, if you're standing and not moving, make that clear, about 90 millimeters of mercury. At the thigh, about 40. The trunk, about 20. Again, the heart, about 10. And the hand, look at this. If the arm is hanging down below the heart, well, the pressure is going to be higher, like 30. If you're going to go raise your hand up, it could be as low as 0. Why is that? It's because of gravity and venous blood, the column of blood. So that's why when someone might be hanging their arm down, you can see the veins bulging out of their arms. If you raise their arm up, those veins go away. It's because of gravity. And you're seeing that in the superficial veins, in the arms like the cephalic and basilic vein. So neck about 0, and then in the head, -10. How can the heck can you have negative pressures? Because you think the veins would collapse. Because they have thin walls, they can actually collapse. It's because of the skull. Because of the skull and because of intracranial pressure, it keeps the veins open because they're in sinuses and all the bones around them will maintain the pressures. Okay, we're getting almost done. So again, our capacitance vessels, So what happens, this is my stick figure walking. So you have muscle contraction. We call this the muscular venous pump. If you stand in one place, the venous pressure is really high, and if you start walking, you can go down to like 50, 40, even down to 30, because you're walking, you're contracting the muscles, your calf, your thigh, your trunk, and it's pushing blood back to the heart. We call it the muscular venous pump. They're constricting the deep veins within the legs, helping push that blood back. Here's your CVP, again, like 8 to 12 millimeters of mercury. That's all I have to say there. Nice and short. So what if someone's laying down? If you lay down, well, the pressure's going to be like 0 to 10 because it's all flat. We take the column of blood. We went from being vertical. Now we have it horizontal. All right, it's lowering our pressures. Like they're 0 to 10. But they're pretty much the same. Many lower in the skull, but about the same all the way across because the column of blood is now sitting down. Last thing in veins, okay, muscular venous pump gets blood back to the heart. What else keeps from blood, quote unquote, pooling in the feet? Blood doesn't pool in the feet, it just moves through slower. It causes venous stasis, but blood is coming back just slower. It doesn't just sit there and become completely stagnant under normal circumstances. These are veins. So in veins, as blood's coming back from the lower extremities, once it gets past this vein, it can't retrograde back, right? Valves are for preventing retrograde flow. In the heart, they prevent retrograde flow. In the lower extremities, they prevent retrograde flow. So again, we increase venous return, we increase preload, we increase our end diastolic volume, which should increase our cardiac output. And also decrease intrathoracic pressure. You breathe in. When you breathe in, the pressure in your thoracic cavity goes down, and this puts less compression on the veins and can increase venous return. We're going to get done within an hour. Last thing, oh God, capillary hemodynamics. Remember, so capillaries, we're all the way down to capillaries. They do not have smooth muscle. They're a single cell layer thick of just this endothelium. Why are they so thin? Because this is where we have exchange of nutrients, exchange of electrolytes, exchange of gases, where water can move in and out. Large things like proteins should not leave. Red blood cells, white blood cells, platelets under normal circumstances should not leave. Okay, there's inflammation that changes things, and we'll get to that later. So there's 3 forces. Before we just talked about osmolarity, right? You give a hypertonic fluid, it's going to pull fluid into the vessel and away from the cells. You give a hypotonic fluid, fluid will go out of the cell and should shift into the cells. So these 3 forces. So first we'll talk about hydrostatic pressure. Hydrostatic pressure is just the blood pressure. It's literally the pressure in the vessel pushing out against the wall. It's like what your venous or arterial pressure would be. It's always an outward force. We increase hydrostatic pressure, we increase the probability that fluid's going to leave the vessel. Now, osmotic force is usually interior force, but it depends on the osmolarity of the fluid. And then some people just combine these. I like separating. The oncotic pressure is due to the plasma proteins, specifically albumin, because it's the most abundant plasma protein. Proteins can't leave the vessel, so if you have more protein in the vessel, it's going to pull fluid in based on an osmotic effect. So it's still osmotic effect that's pulling water in, but it's specifically due to protein, so I like separating those 2 out. They're both inward forces. But the arterial end, water's going to leave, fluid's going to leave, because hydrostatic pressure is greater than osmotic and oncotic pressure combined, so fluid's going to leave, water's going to leave and flow into the interstitial space, and then it can move into the cells or just accumulate in the interstitial space depending on what's going on. On the venous end, hydrostatic pressure decreases significantly, and then osmotic and oncotic pressure increase significantly, so we have greater inward force. So osmotic and oncotic are greater than hydrostatic, so fluid's going to move back in. So fluid moves out and then back in, out and back in, out and back in. So, and the last little piece here is, well, extra fluid can always build up in the interstitial space. How do we get rid of that? Well, the lymphatic system, we'll learn about this next, that's going to help suck up the extra fluid, and this takes it through lymph nodes, and this is how part of our immune system works. We'll learn about later, and this cleans up the extra fluid. Okay, so what can cause edema? Edema is accumulation of fluid in the interstitial space. Well, if we know the mechanisms, you'll understand all the causes. So if we increase hydrostatic pressure, we increase outward force. That can happen if blood is backing up into the alveolar capillaries in the lungs, or if blood's backing up into the legs, and they're going to push out more blood. More blood volume is going to increase hydrostatic pressure. It's going to promote fluid to leave the vessels. In the lungs, this leads to pulmonary edema. In the legs, it leads to peripheral edema in the legs. This can be due to heart failure, venous insufficiency, or if anyone's just fluid overloaded, it's going to increase blood volume and pressures and promote pushing fluid out of the vessels. What about decreasing osmotic pressure? Well, decreasing osmotic pressure, if there is a lower osmolarity of the blood, well, there's a less inward force and there can be more fluid leaving the vessel that way. So again, you give a hypotonic fluid or the blood's really dilute, it's going to promote fluid leaving. So again, people are fluid overloaded. That's lowering their sodium and lowering their osmolarity of the blood because it's very dilute because we're holding on all this fluid. It's going to promote fluid to leave. So think about a patient with kidney disease who has missed their dialysis appointment, all filled with fluid. Well, that fluid's going to third space, some people call it, or leave the vessels, go into the interstitial space, cause pulmonary edema, peripheral edema. They're puffy in their face, they're puffy everywhere. Low oncotic pressure. So if you lose protein, there's a lot of reasons for losing protein. So what causes low albumin? So cirrhosis, because these proteins are made in the liver. Your liver's shot, it's all scarred up. You'll have hypoalbuminemia, low albumin in the blood. Nephrotic syndrome, specifically nephrotic, what does that mean? This is when your patient has kidney disease, but they're peeing out more than 3.5 grams of protein a day. By definition, they'll have hypoalbuminemia, lower their oncotic pressure, so fluid's going to move out. Cut off kwashiorkor. So kwashiorkor is not just malnutrition by calories, that's called marasmus. It's protein malnutrition. So if you're eating calories, but your protein is low, fluid's going to leave the vessels. And when that happens, you have edema. There you go. The end. Hopefully this helps.